Assalamu alaikum. Today we will talk about acute interstitial nephritis, one of the main pathologies of acute kidney injury. Acute interstitial nephritis is acute kidney injury which is characterized by inflammatory infiltrate in the kidney interstitium. What is kidney interstitium? Kidney interstitium is the area surrounding the tubules. As we see in this picture, there is tubules or nephrons which is surrounded by interstitium. Inflammation is in this area. When we talk about etiology, around 2/3 of cases are secondary to drugs. The most important drugs are painkillers like non-steroidal anti-inflammatory drugs, antibiotics like penicillins, cephalosporins, trimethoprim sulfamethoxazole, which is Septrin, and quinolones like Cipro. Also diuretics like furosemide and thiazide. And one of the most common drugs we use in ICU is PPI. Omeprazole and lansoprazole can cause acute interstitial nephritis. The second cause is infections. Infections, bacteria like Legionella, Streptococcus, Enterococcus, and E. coli, viruses like cytomegalovirus and Epstein-Barr virus, and fungi like Candida and histoplasmosis. We can also see acute interstitial nephritis as a part of systemic disease like systemic lupus erythematosus, Sjögren syndrome, and sarcoidosis. And there is some cases we can mention it as idiopathic. The most important syndrome in this idiopathic pathology is tubular interstitial nephritis and uveitis syndrome, which can be presented with acute kidney injury plus anterior uveitis, as we see in this picture. The pathophysiology of drug-induced acute interstitial nephritis is mainly secondary to immune mechanism. Drugs act as antigen and binds to tubular cells in the interstitium, and this generates a host immune response, and we can see in these cases IgE may be elevated. So when we talk with our patient, we have to discuss his drug history and never forget that there is a latent period and maybe up to several weeks, as the patient may take these drugs 2 weeks or 3 weeks before and present after that with acute kidney injury. Acute interstitial nephritis due to infection, it is not very clear, but the main theory is bacteria can deposit some antigenic materials in the tubular basement membrane, and this can generate a host immune response. How can be the patient presented with acute interstitial nephritis to ICU? Firstly, we have to mention that physician must pay attention to drug history and never forget that there is a latent period and maybe up to several weeks. And the patient may be oliguric or non-oliguric. And there is triad of fever, rash, and eosinophilia, but it's not very common. It's present in only around 10 to 20% of cases, and there is minimal proteinuria. And also, we are sure there is rising serum creatinine. Don't forget to do basal labs or basal workup for AKI. And in some cases, we might need biopsy to confirm this diagnosis. In this photo, you can find the rash. So if you found the triad of rash and fever and eosinophilia in a patient presenting with AKI, you have to consider acute interstitial nephritis. To treat this case, you have to discontinue the offending drug. This is the first step. And if the cause is infection, you have to control this infection with antibiotics or source control. And if the cause is other causes like association with immune system disease, you have to control this. The second treatment or the second line of treatment is steroids. We have two main approaches. The first approach, we start with pulse steroids around 500 milligrams up to 1 gram of methyl prednisolone for 3 days, and then continue with prednisolone 1 milligram per kg. Or from the start, we can start with prednisolone 1 milligram per kg. If no response to this initial therapy, we can use MMF or mycophenolate mofetil if there is no response to steroids. So the question here, which line we will use in steroids? We start with pulse steroid or we start with oral therapy 1 milligram per kg. This study was published in Saudi Journal of Kidney, and there is also multiple studies about this issue. It's talking about drug-induced acute interstitial nephritis, prospective randomized trial comparing oral steroids and high-dose intravenous pulse steroids in guiding the treatment of this condition. We found in the results that there is no significant difference between the two groups. Pulses of high steroids of corticosteroids may have significant but transient anti-inflammatory effect, but both oral and IV pharmacological ways to treat acute interstitial nephritis are equally effective. And if the patient developed any complication of AKI like uremia, like electrolyte disturbance, you have to use all lines of treatment up to dialysis. Thanks for your attention.